Well, hello everyone, and welcome to the nuts and bolts of point of care echo, the 5E's in COVID-19 webinar with Dr. Rachel Liu. I am so glad to have you all here for this educational opportunity gathered from across the United States and beyond. It is incredible to have you, so thanks for tuning in. My name is David Murray, and I am the Point of Care Ultrasound Learning Program Manager for North America, and it is a pleasure to present this opportunity on behalf of Philips Ultrasound Clinical Education. Today's webinar will be in a lecture format with Dr. Liu, followed up by an opportunity for question and answer, time permitting. A couple of matters to address before we begin the lecture with Dr. Liu. Please place your questions in the Q&A submission tool you will see in your participant bar at the bottom of your screen or top of your screen, depending on how you're logged into this meeting. So if you're in a smart device like your phone or tablet or on your desktop or laptop computer, that may be found at the top or bottom of your screen. Submit those questions throughout the lecture. And after the lecture is complete, I will address as many of your questions as possible with Dr. Liu during that Q&A session. Due to the number of attendees and questions we're likely to receive, we may not make it through all of your specific questions, but I will do my utmost to identify as many unique and pertinent questions, categorize those, and pass them along to Dr. Liu. So I appreciate your understanding of that process. All right, so with all that out of the way, it is my pleasure to introduce our esteemed speaker today. Dr. Rachel Liu is an emergency medicine physician and assistant professor at Yale New Haven Hospital. She is also the director of the clinical ultrasound education for Yale School of Medicine. Dr. Liu is a noted clinician, researcher, educator, and point of care ultrasound expert. She is a past president of the Academy of Emergency Ultrasound and a past chair of the American College of Emergency Physicians Emergency Ultrasound Section. She has won several teaching awards for her innovative work in developing novel education strategies and programs to teach bedside ultrasound, and it is a great honor to have her with us today, particularly, again, because she's giving us her time while she's on the front lines of fighting COVID-19. So, Dr. Liu, thank you so much for being here with us today. We're really privileged to have you, and with that, I will hand over the virtual microphone to you.
Great. Thanks very much, David and Phillips, and to all of you for listening to this talk. And I'm just going to screen share here. Let's see. Okay. Right. So today I just want to give a basic overview of point of care echocardiography. And this is really kind of tailored towards people who are not too familiar with echo and want to see the point of care space. I do realize that we have some cardiac sonographers and cardiologists in the audience, and so some of this can show you how we're currently using it both in COVID times and out of COVID times. But we're going to start off with just some very basic nuts and bolts kind of stuff, like how to orient yourself and a little bit about how to scan, and then concentrate more heavily on the pathology and implications in COVID-19. So if you're interested, there's numerous papers out there that highlight point of care echocardiography protocols. Here's one that we wrote focusing on the 5E's, which we've been teaching because it's a really nice mnemonic to remember what kind of pathologies that we're looking for. So I just wanted to start off a little bit about orientation, and for those cardiac sonographers and cardiologists in the audience, how I do it may look backwards to you. So there's several ways that people have been doing orientation across the country and even across the globe. And one follows the general kind of radiology convention where the screen indicator is placed on this side of the screen, whereas cardiology places a screen indicator on the opposite side. And what that means is that although some of our probe positioning may be similar, the images on the screens will be flipped. the reason why those of us in EM, ICU follow the general convention is that in all the rest of point of care ultrasound, like abdominal scanning, vascular scanning even, the screen indicator is on this side. And so we don't necessarily want to confuse our users by flipping it just for cardiac applications. And there are a good, probably half to majority of EM intensivists, other specialties who still do it cardiology convention. So just knowing that both of those exist is key. Neither of them is right or wrong, just we got to know what we're looking at. And so again, for those of us following general convention, our axis is going to be, pointed towards the patient's right, whereas in cardiology, the axis is the opposite. So I don't want that to be too confusing, but you'll see it in general convention throughout this talk. So let's start with what views. And we're going to be using most typically a phased array transducer, which is a low frequency 3 to 5 megahertz probe with a footprint that's square. And it's square to accommodate being able to fit in between rib spaces. And I think echo is kind of like the rule of fives. So we're going to talk about our 5E's later, but we have 5 main views. And those views are the peristernal, long, and short axis, the apical 4-chamber view, the subxiphoid view, and then turning to a long axis or sagittal section in the subxiphoid area so that we can image our IVC. And so our 3 main areas are peristernal, subxiphoid, and apical. So I'm going to go through each view briefly, but I just want to also put this here so that we can remember that our heart is not only lying obliquely in our body, it also is rotated. And so while it's rotated, the RV is the chamber that actually takes up most of the anterior chest wall space. And this is going to be important when you try to orient yourself. So let's start with our peristernal long axis. For a lot of us, this is our go-to first view. I'll show you situations where that might not be possible or true in terms of patient positioning later. But this is generally, we're putting the probe in roughly the 4th or 5th intercostal space, and that translates to roughly the nipple line. And my probe marker is oriented towards the patient's right shoulder. So that means everything on this side of the screen, indicator side, is the patient's right, and everything on this side is the left. And so I'm going to think of what chamber my sound wave is going to hit first. So I place the probe on the chest, my sound wave is now entering the chest wall, and it's going to hit the right ventricle first, and then the left ventricle behind that. My left atrium is connected to the left ventricle, and I can actually see the mitral valves here. The mitral valve is connected by the chordae tendineae to the papillary muscle, and blood is going to come from my LA to my LV and out the aortic outflow tract. So this is my aortic outflow tract here. This circular area is the descending aorta, and I can see that it's outside my pericardium, and the pericardium is this bright white line here. And if I think about it, knowing that the heart is oblique and kind of rotated, the reason why I'm pointing my probe marker to the right shoulder is that if an oblique section is going to get me a long axis, and when you split a long axis cone, the split ends up being roughly triangular. So I have like a kind of triangle shape to my peristernal long axis here. So again, here's my peristernal long axis, and the chamber that's most anterior is the RV. Then posterior is LV. I can see my mitral valve, my chordae tendineae, and my papillary muscle. My LA is just beyond that valve. And then my aortic outflow tract is there, and it loops around to start becoming the descending aorta that will turn into abdominal aorta in the abdomen. One reason why we like this view is it gives us a really nice overview of whether we have a pericardial effusion, what our global heart function is, some chamber size estimates, and this is our view for estimating the aortic diameter. So this is the peristernal long axis. Now let's go to our peristernal short axis. And in the same exact position where I put my peristernal long axis probe, I don't actually have to slide or move it away from that point. All I have to do is rotate. So we're moving from a long axis to a short axis, which means it's the opposite, like kind of perpendicular plane. And to get that perpendicular plane, what I need to do is rotate 90 degrees. And because we keep the screen indicator on the patient's right, that means I'm rotating towards the patient's right hip. So when we transect a cone into its short axis or kind of transverse axis, we get a more circular object. And this clip will show you exactly that. It's someone rotating from a peristernal long axis to the peristernal short axis. I go from seeing 4 kind of structures to now seeing 2 structures. And those 2 structures are going to be my LV on the patient's left and my RV on the patient's right. And here's the corresponding RV, and once it flips, LV. So this is one of our typical areas. This is the mitral valve view. And they have rotated the probe marker towards the patient's right hip. So my RV is here. I can kind of make out my tricuspid valve there, so that makes this the right atrium area. And then here's my circular LV with these kind of flapping cusps. And these flaps are the mitral valve. And some people think it looks like a goldfish mouth opening and closing. So some people refer to this as the goldfish mouth view. But what it really lets us do is look at the circumference of the LV and start determining kind of LV global function. We can look at the LV in specific regions, and it also lets us estimate some chamber size. These regions are typically kind of 4 areas. So your aortic area, if I fan towards the base of the heart, through to the papillary and apical levels if I fan towards the apex. And so up here in the corner, this is what an aortic view looks like. In point-of-care echocardiography, in point-of-care echo, there isn't a huge use necessarily for the aortic valve view, except in the specific cases. But I'm just showing this here so that people know that when they put the probe down and it looks like this, that this is actually what they're seeing, the aortic valve view of the peristernal short. Then we come through to our mitral valve, and if we fan further down towards the apex, we're going to get these 2 things that kind of look like crab claws. So when you see crab claw sort of pincers that are moving, these are your papillary muscles. And so your papillary level is right here. If you fan down even further towards the apex, then what happens is you'll see the LV lumen becoming quite small as you reach the tip of this cone. And so a lot of our assessments are done kind of in the mitral valve papillary area, sometimes the apical area as well. So that was the peristernal short axis. Next, we move to our apical 4-chamber. And our apical 4-chamber view, I will say, is probably one of the hardest views that we can get. It's tricky, particularly in point-of-care echo when our patients aren't exactly able to lie on their left sides like they do in echo lab. You may also be dealing with intubated patients, patients who are quite dyspneic and not really able to comply with your positioning. So this can be pretty tricky. I like to landmark the nipple because I know my 4th or 5th IC space is there. I have a little bit of kind of body and fat tissue to anchor in. And I find that a lot of, especially new trainees, will start their apical four chambers very laterally. And when you do that, there's no landmark to really see. And so you're kind of like in no man's land. So I like to see where there's a beating heart and then kind of follow through from there. You do have to increase your depth in order to get the sound wave to fully come or cover the heart to its apex. And to do so, that means you have to aim the probe tail flat towards the body. And so instead of getting a nice cross section of just the apex, now you're going to expand out that view to involve all four chambers from kind of upside down. And this is what it looks like. So the apex is closest to my probe footprint. I'm seeing the right ventricle on the patient's right side, and there's my right atrium with the tricuspid valve in the middle. And then here's my LV, my mitral valve is right there, and then my left atrium. And so for us in the general convention, I'm pointing my probe marker to the 9 o'clock position as much as I can. And as I get my apical view, I'm trying not to really rotate the probe marker that much. Otherwise, I'm going to end up getting a foreshortened RV and getting chamber sizes that are not necessarily accurate. But this is a great view for assessing chamber size, and we can also assess for things like overall function. And just a note that for those of us who do more advanced echo, this is one of our go-to views for doing measurements, Doppler, and whatnot. So next we come to our subxiphoid view. The subxiphoid view can also be challenging in some patients, but it may have advantages in certain situations, like if you have an intubated patient who's lying completely flat and their cardiac view or their heart has kind of sunk into their body. It's one of our go-to views for trauma, just because it's great for effusion and because of the way trauma patients come in sometimes. And it's a go-to view for really critically ill patients when things like Zoll pads or EKG leads are being placed on the chest wall. Like the apical, we do need to increase the depth so that we can really get that sound wave into the chest wall. And to do so, we also will need to flatten the probe tail against the body. And in the subxiphoid area, we're just underneath the xiphoid process, and we're going to actually use the kind of lobe of the liver to help us get our view. So you're shooting through the lobe of the liver and approaching the heart from this angle. And so what I'm going to see is my liver closest to the footprint, followed by my RV, my RA, LV, and LA. And so, as I said, this is one of the go-to views in trauma because this is a great way to assess for effusion. It's also good for things like function and chamber size. And the last view that we come to is our inferior vena cava view or subxiphoid long axis. And from that subxiphoid position that you were just in, all you need to do is rotate the probe marker up towards the head to obtain that long axis. You also need to tilt into the chest wall to get the IVC dumping into the right atrium. And so it'll look kind of like this. The liver's here, and then your IVC can be seen connecting to the right atrium. You may need to fan the probe slightly to the patient's right because we know the IVC does come through the liver area. So if you're not seeing what you need to see, try fanning a little bit towards the patient's right. So there we have the views. We have the peristernal long short axis, apical four chamber, subxiphoid, and the subxiphoid long view. So what do we do with that now? I want to know what pathologies are most important to prevent or predict the crashing patients. And in this time of COVID, it's really hard to determine what's what because all our biomarkers, our lab tests are elevated. Our ability to get advanced imaging is limited, but I need to somehow decide on treatment pathways. And so we developed a mnemonic outside of COVID times called the 5E's, and it's proven useful in this current time as well. So the first E I want to know is, do I have a pericardial effusion? And if I do, is it tamponade? Do I need to really intervene? And tamponade has been thought of as a more clinical diagnosis. You can have your Beck's tried with hypotension. What we're really trying to do with echo is to pick up earlier signs of tamponade before the severe clinical signs manifest. Next, I'll try to see if someone has ejection problems. And ejection is, how well is my LV in particular squeezing? Is it adequate, or is it squeezing quite poorly? Do I have to think about a cardiogenic shock picture? Equality. Is my RV greater than my LV? And if so, does that mean that this person might be suffering an acute pulmonary embolus? Exit. Is my thoracic aorta enlarged? Does that mean that I should be considering a thoracic aneurysm or even a thoracic dissection? And lastly, entrance. Is my IVC flat, or is it backed up and stuffy? What is my preload doing? And so these are the 5E's that, that we try to evaluate with every one of our echo applications. One of my friends, VM Din, whose Twitter handle right now is POCUS101, if you want to follow, has made a really nice organization chart. And so we're going to be going through a lot of these today, but if you want a framework to reference, he posted this really nice kind of algorithm. I'll also say that when someone with potential COVID is presenting with shortness of breath or chest pain, it's really helpful in terms of POCUS, cardiac ultrasound, and lung ultrasound to avoid COVID bias, in that it can let us know other pathologies other than COVID-specific lung disease that we should be worried about. So let's go through the first E, effusion. I want to know if I have a suffusion, which I see this here, and I'm seeing this anechoic stripe of fluid that's circumferentiates the heart. I want to know, is it significant? And by significant, I mean, am I worried about developing tamponade? Am I seeing early tamponade physiology that I should intervene on immediately? And there's a couple qualifications that we use for that. We can try to measure the actual size of the effusion. And often I don't actually measure, I more eyeball it. But if I'm eyeballing it at the largest point here, and I go to my side measurement markers, I'm going to estimate that this area is almost approaching 2 centimeters. And so that's pretty large. The real thing I'm looking for is RV diastolic inversion. And what that means is, in diastole, the ventricle is supposed to fill, and it's supposed to fill fully. But when you have an external pressure from the tamponade coming in, the pressure of the RV is not able to like poof itself out enough to handle the external pressure from the effusion. And so you get this RV free wall dipping into the RV lumen in diastole. How do I know what's diastole or not? Diastole happens when the valve opens so that the blood can rush in and fill the ventricle. And so I'm really looking at the anterior leaflet of the mitral valve here. When it hits the septum, that's diastole. And every time it approaches the septum here, every single time I'm timing it with this, and it looks like the RV is inverting when the valve opens. So this to me would be an early sign of tamponade before clinical signs like severe hypotension manifest. We'll get to some of these later, but other signs on basic echo that indicate early tamponade
are RA systolic and diastolic collapse. Later on, when it's actually quite severe, you get heart swinging in the pericardial sac. And usually at any stage of this time period, your RV and RA cannot really fill properly. So then it backs up into the IVC and you'll get IVC plethora. So there's the effusion. And for those people who like kind of visual things, some people think it looks like a T-Rex chomping. Kind of really don't see the T-Rex face, but I guess I could really do it if I use some imagination. Okay, so what about this one? I think I see a pericardial effusion. I have the circumferential anechoic stripe that is surrounding the heart, and I want to know if there is tamponade or not. And if I look at my mitral valve opening, it's hitting the septum, and every time it does so, my RV is still kind of plumped and fully dilated. So I think while we have an effusion that we really need to keep an eye on, I don't think at this point in time we have tamponade. That doesn't mean that the person, you can forget about the person and you don't have to watch them. It just means at this current time, that's not part of the physiology. Here's an apical four-chamber view that also shows me an effusion that's circumferentiating the heart. My pericardium is right there. And again, if I'm looking at the RV, I don't see the RV free wall that well, but I'm not really seeing any signs of RV intrusion. So what about this one? I have my pericardial effusion. It looks kind of really weird because we're not used to seeing an echo image look like this. And here is my RV. And every time diastole happens, which is when my valve opens, there's severe intrusion of this RV wall. And so my RV is not filling. This is tamponade. And then most certainly, here is the heart swinging in the pericardial sac. This is the reason why we get electrical alternans on our EKG, because the heart is literally swinging to and away from an EKG electrode. And obviously this is fairly emergent. The other thing that we have to think about with effusions is we have to be sure that we have a pericardial effusion. And we're going to use our descending aorta to help us out. So I'm going to locate my descending aorta in both these images, and that's here and here. In image number 1, this fluid is circumferentiating the heart and appears above the aorta. So that means this is pericardial, and this is my pericardium. Whereas in this image, I don't really see fluid circumferentiating the heart. Here's my descending aorta, and the fluid falls below or outside the descending aorta. And that means this is pleural. So this is a pleural effusion, not a pericardial effusion. And it does help to increase the depth of your peritoneal lung if you really are truly thinking about pericardial versus pleural effusion, so that you can see the fluid fall outside of your aortic landmark. Here's a couple apical four-chamber views, and I want to know where the effusion is. And so on this image, it may be a little bit harder to see the descending aorta, but it's probably roughly around here. And if I draw a line from this aortic area to my pericardium, fluid falls inside that line. So this is pericardial. Whereas in this image, here's my descending aorta. I draw a line from it to the pericardium, and the fluid falls outside. This is pleural. It can be pretty tricky to tell though. And the other thing that we have to watch for is fat pads. So if I'm in my peritoneal long axis view here, I see a hypoechoic area right on top of the RV, but it's not truly anechoic. It's got some stuff in it. And that kind of grayish stuff is moving with the heart. And so this is most likely an anterior fat pad, as it does not track around the heart either. If you're questioning whether you have an effusion or a fat pad, and actually in anything that you do with echo, you want to image in multiple views, because the subxiphoid view of this peristernal long also shows that you have an anechoic area with some gray spots that are moving with the heart, and that would be confirming your fat pad there with no effusion circumferentiating. So, anechoic fluid obviously doesn't move with the heart. What about clot? What about if you had blood in your pericardial sac and it clotted and it also appears gray? It can look like this a little bit, but the difference is that a clot will not move with the heart. The heart will actually move against that clot and kind of beat up against it. And so those are all features that tell me clot versus fat pad. A bit of a rare instance. So to recap, here's one of our recent young patients, someone presenting with some chest congestion, chest pain, shortness of breath. The blood pressure was about 110/72. And she was admitted for a COVID rule out. And we did the echo and realized that, hey, there's an effusion here. This is a subxiphoid view. Here's my liver, but there's an effusion here. And not only that, if I'm trying to time my, RV wall intrusion, the RV really is not filling very well. It looks rather tiny. And every time this mitral valve opens, I can't be sure, but it looks like the RV wall is definitely not plumping anyway. And I'm also starting to get intrusion of the right atrial wall here. So now I'm concerned about developing tamponade. And so these are the things I'm looking for. Not only that, if I further look at the LV and pick a spot in the middle and try to see how well the walls are squeezing towards that middle spot, it's not squeezing very well. So now I've got someone with a sounding like viral leg syndrome with chest pain and shortness of breath, and her LV is not contracting well, and she also has a pericardial effusion. Now I'm going to start worrying about significant myopericarditis, which can be a feature of COVID. And while we're on the last point, it's time to move on to our second E. Our second E is ejection. How well is the heart squeezing? Here, you've seen this before, rather normal looking, happy LV. If I pick a spot in the middle here, all the LV walls are contracting in towards that middle spot. My anterior mitral valve is hitting the septum like it's supposed to. And so this tells me that things here are fairly normal. This is an example of a hyperdynamic heart. Hyperdynamic hearts are typically thought to be with severe hypovolemic states or sepsis. And here is the LV trying to really slam together to squeeze every bit of cardiac output from the body. And so hyperdynamic is really kind of slamming of the LV walls there, and it's associated with an ejection fraction of roughly around 70% or above. And so this tells me that this person needs some kind of volume and treatment, like maybe antibiotics, fluids, and whatnot. And then here is an example of a rather severely depressed LV, probably actually global depression as well. And if I pick a spot here in the middle of my LV, the walls are not contracting towards it at all, and my anterior mitral valve leaflet here is nowhere near connecting with the septum. And so this person's EF is probably, I'd say, even like 10% if I had to give a numeric estimation. So these are kind of the whole ranges of ejection fraction. And there's some advanced techniques that you can use to try to help yourself out, but globally eyeballing, I think you can see the difference between all of these images. So here's one from about 2 weeks ago, and yet another patient complaining of shortness of breath, fever, and walking dyspnea. And you know, the lungs showed, you know, not too bad, B lines and everything, so we moved on to her heart. And if you're interested, by the way, in the lung ultrasound aspect of COVID, there's numerous webinars out there, including one that we did with Philips about a week and a half ago. But anyway, we moved on to her heart, and for a young person, I wasn't expecting to see this. And what I'm seeing is, you know, I think the LV walls here are moving towards this middle space, okay, but when I look at this anterior leaflet of the mitral valve, it is not hitting the septum like a normal person with normal ejection fraction should have. And so I can't really see her apical area very well. Again, if I'm trying to look into the valvular space, I'm not seeing anything that definitively hits the septum. And so, like, a young person should not have a depressed ejection fraction. We actually measured her diastolic function in the ED as well, and her diastolic function was, she had some diastolic dysfunction as well. So she ends up getting admitted for further investigation, a COVID rule out, and for a complete echo to figure out why a young person should be having this at this stage. And again, I'm really looking at the mitral valve area, especially in these cases that are not really slam dunk. So just a couple areas where this can't be used reliably is when you have an arrhythmia. So for example, this image, you would think maybe that the EF is depressed here. It's quite bradycardic, but every time the heart actually squeezes, it squeezes well. And it's actually an arrhythmia that's throwing us off. And so this ends up being third-degree heart block when I looked at the EKG. And so arrhythmia does not mean that EF is poor, but there's some conduction thing or something that's making it look strange to you. Valvular disease and other structural or conduction defects can also throw off your estimation of ejection fraction. So that was it for our second E. But I'm going to talk a little bit about this. So one of the really tricky things, especially in COVID, is that patients are presenting kind of STEMI-like, ST elevation MI-like, and the procoagulant nature of this disease is pretty confusing. The troponins are always up, the BNP, the D-dimers, they're up. And so we're really relying on what we see on echo to help us with determining what's going on. And so this is more of an advanced topic, but a lot of us are looking for regional wall motion abnormalities as well. And how you do that is with, typically in point of care, a peristernal short axis view. So I got my peristernal short axis, and if I pick a spot in the middle here, I'm trying to see how well the LV circumference wall is going towards that middle point. And I see these walls moving, but I don't see any of the motion down here. And how that corresponds is with a mnemonic that we call SALPI, again, 5 areas. So the septal area, anterior, lateral, posterior, and inferior. If you're a cardiologist, you're looking at many more areas than this, but just our eyeball guesstimation in point of care is these 5 areas. And I can see that my posterior inferior areas are the areas that are not moving, and I can correlate with that EKG here that's actually showing inferior ST elevation changes. And I can call the cath lab and say, hey, listen, we've got corresponding regional wall motion abnormality here. In these COVID times, it's a little tricky to know exactly what the management is because they need probably to be ruled out for COVID first, but at least I can tell what's going on with the patient. Now here, where do we think the defect is? So here's septum, anterior is not moving very well, lateral is moving okay, posterior and inferior moving okay. So my defect is anterior. So that's what regional wall motion abnormality looks like. I will say it's also pretty tricky and can be really hard to decipher by the naked eye. Our third E is equality. And this is also very important to us in our COVID procoagulant era. And for equality, I'm really looking to see if the RV is appropriately smaller than the LV. And the normal RV to LV ratio is RV is about 2/3 diameter to the LV. And if I start getting bigger than that, like approaching a 1-to-1 ratio or even greater, I'm going to start getting concerned. And so here's a couple of peristernal long axis views and an apical view that's sideways. It's too medial, so that's why it looks sideways. And here's my right ventricle. It starts looking like a ball instead of like a triangle. So I know the kind of morphology and the pressure inside is poofing that RV out. And not only that, my LV here kind of seems impacted. It looks like the septum is getting pushed into the LV. And similarly, in this off-axis apical four-chamber view, I'm getting an RV that looks ball-shaped instead of triangular. And the septum looks like it's kind of getting flattened or pushed into the LV instead of expanding in diastole like we've been talking about. And so both of these images display something called McConnell sign. And McConnell sign in the acute phase can be pathognomic for something like a PE. And what I'm looking for is really this akinesia of the RV free wall. So if I'm looking at the RV free wall here, it's not moving at all. But if I'm looking here at the apex is moving. So it's RV wall akinesia or hypokinesia with apical sparing, plus the potential for paradoxical septal motion, which is, as I described, septal flattening when it's not supposed to be flat, particularly in diastole when the LV is supposed to fill. And we can confirm that with our peristernal short axis view, which is here. And so my RV is on top, my LV that is normally a nice O circular shape is now a D shape. And when that O becomes a D, that indicates the septum has flattened, and this is called D sign. So I'm going to share a case with you, and it's rather dramatic, but does anyone have a clue what's happening in this image? This is a subxiphoid view, and it's what it looks like when you are doing echocardiography with CPR ongoing. And this is a whole other lecture that I give, but compressions are happening, and so we can't really see much of the heart. But this is during one of the pulse checks. And I'm not seeing my classic subxiphoid view, because obviously when we do these lectures, we're showing you very pretty pictures. But here's my subxiphoid view. I know my RV is supposed to be here, and I'm seeing an RV that looks rather ball-shaped and not really triangular-shaped. So that's going to start getting my radar up. And not only that, in this pulse check, I'm actually seeing kind of fibrillation of the whole heart. And so to me, that means VTAC or VFib, unless shown otherwise. And the problem with this is that the monitor won't actually show VFib or VTAC. It's mainly on echo. All right, so we continue ACLS, and kind of we get her back a little while later. And I see this on my apical four-chamber view. My RV here is so large that it's really pushing the septum here. And now my LV has actually almost become triangular, and this is not a normal shape for that LV. And so I'm now kind of certain in this code that we're dealing with macroscopic occlusion leading to a large PE. And this is a young COVID patient who was known to be positive, who essentially coded right in front of us. We gave TPA twice, and maximally on 4 pressors, she was not able to sustain this function, and she unfortunately passed away. But using echo in the middle of this code told me what I was dealing with and how I needed to treat it. So that was the equality part. Now we're on to our 4th E, and I'll just kind of gloss over this a little quickly. This doesn't really seem to have too much bearing in COVID, except that all our D dimers are elevated, and so you don't know if you're dealing with a PE or a dissection or something else. And on this coast, or at least in my hospital, we actually see quite a few cases of aortic dissection. And so this is very high on our radar because the incidence, I really believe globally, is higher than what we've been taught from textbooks or whatnot. So we include assessments of the thoracic aortic diameter in almost all of our ED echoes. And what I'm looking for is a diameter larger than 4.5 centimeters or approaching 4.5 centimeters, because this can indicate that there's a thoracic aneurysm or dissection until proven otherwise. The measurement here is normal. There's the person made a mistake in measuring twice, but the measurement here is normal. What about this one? So this is a patient who complained of chest pain and then migratory paresthesias all over the body, and then was noted to be quite unwell in the triage of ED. And so when they did his echo, it is 1, 2, 3, 4, 5, 6, almost 7 centimeters. And I'm actually seeing a dissection flap here in the aortic outflow tract. And, you know, transthoracic echo is not necessarily the gold standard for picking up thoracic aortic dissections or dissection flaps. But of course, when you can see it, you see it. So there we go. And this is actually that person's X-ray, which I guess if I look really carefully, I might think it might be slightly widened, but honestly, it's not looking that impressive to me. And then this patient was stable enough actually to do a quick CT. And then this is that dissection seen here on CT, and basically goes from potentially being a chest pain rule out in our chest pain center to all of a sudden going for cardiothoracic repair. And we've seen this kind of over and over again in our institution. So that was exit. And lastly, we come to entrance, or what is my preload doing? So in a normal patient, you know, I don't actually regularly measure the diameter of the IVC, but I'm more looking qualitatively to see that it's not engorged, it still flattens a little bit with respiration. And so here's someone doing a sniff test to show the IVC collapsibility there. Here, someone doesn't even need to sniff in order for the IVC to flatten fully. And so with normal respiration, the IVC is flattening, which means I don't have enough volume to plump up the IVC and keep it open. So this is a quite flat IVC. And then here is an example of a plethoric IVC where just by eyeballing, it looks rather large. The person tries to sniff, and there's no collapsibility of the IVC walls at all. And in addition, I see this kind of gray stuff, and this gray stuff is known as smoke. And it's thought to be the blood flow is moving slow enough that the sound wave is really able to ping off kind of RBCs or structural things that are in the blood. And this tells me that the heart's not able to fill for some reason or another, and so everything is getting backed up into the IVC. And this is kind of how we use IVC to look at volume status, especially in COVID times. We want to make sure not to overload patients because it may be detrimental to their care. So that was our 5E's, and I just wanted to go through a couple COVID patient cases. And so this is a young lady who is known to be COVID positive, but feeling worse roughly around the 7 to 10 day time point. And most often we are doing echoes in conjunction with our lung. So I wanted to share that I have a normal ejection fraction here, which is reassuring to me. I do have findings, and again, if you're interested, there are lung webinars out there, but I do have findings of potential viral or COVID-induced disease in my lung views with kind of these patchy B lines here. And I do also want to reiterate that when I see kind of these lung findings and B lines, that doesn't necessarily mean the person has COVID. But since this patient already tested positive for COVID, I can assume that these lung findings are because of that. And so even though she was feeling worse, even though I was able to see that she had findings of COVID, I was reassured in that she did not seem to be having any myocardial depression or any of the other 5E's being positive. Her walking O2 sat was still normal, and so she was discharged to close follow-up at home. This is a patient who is dialysis dependent, also known COVID positive, presenting with very significant shortness of breath, and was 60% on room air oxygen when the patient came in with their shortness of breath. And so 60% would normally be really, really terrifying for most of us. But as he looked okay, even though he was tachypnic, we made the choice to try to defer intubation and place this patient on high flow nasal cannula, and that worked for a little while. So here's his first echo view in peristernal long axis, and I have a nice ejection fraction here, which is pretty reassuring to me because in a dialysis patient, I want to make sure that that person doesn't have any reason necessarily cardiac-wise to be fluid overloaded. And so then I move on to his xiphoid view. I'm not really seeing any pericardial effusion. Again, I'm seeing all function of the heart looking fairly okay, even though I have a lot of kind of artifacts here. I move on to the apical view, and like real life, some of this is grainy, but I can be reassured that his RV is not poofed out and can be triangular shaped, and his LV is functioning okay. So that tells me I don't have to be dealing with a PE on top of this. And then when I look at the IVC, it doesn't look huge to me. It still has some collapse on respiration, and that collapse is happening very quickly because he's pretty tachypnic. And so this whole picture lets me be more reassured that he is not suffering from fluid overload at this stage due to his dialysis baseline, but more from his COVID disease, which is placing his oxygen needs very high. When I look at his lungs, I'm seeing evidence of kind of interstitial water everywhere in patchy points. And that patchiness, along with some of the irregularities that appear along the pleural line, let me know that I think I'm dealing more with a COVID process, not as much of a pulmonary edema fluid overload process. And so this gets really tricky. This is not necessarily the easiest to do, and there's a lot of gestalt that has to come with using POCUS in our clinical managements. But these are just some examples of how POCUS can help me rule in things and rule out things, more importantly. And so this is sort of an informal algorithm that I use in patients who look fairly well and they might be complaining of chest pain and shortness of breath. We're pretty liberal at doing point of care echoes to rule out serious causes that might not be apparent on physical exam. If it looks okay and the patient might be kind of COVID negative or they're still pending their workup, we may consider things like our chest pain center rule outs for ACS if they're COVID negative, or pursuing telemetry admits for COVID pending patients. For anyone who is being admitted for hypoxia, chest congestion, shortness of breath, but with that hypoxia, we're actually trying to do baseline lung and echo for all admitted patients. And this is so that our cardiologists have something to look back as a baseline if the patient deteriorates while in the hospital. And so it's used for kind of monitoring, progressive monitoring, more often in ICU settings, but also can be applicable to the floor settings. And in those critically unwell patients who you know are COVID positive and you know are very sick just by looking at them, you don't necessarily need lung ultrasound, but it's very helpful for us to rule out other causes of shortness of breath or chest pain. And as I showed you, brief guidance in cardiac arrest. So here it is. We're using our heart. The heart gives us probably 90% of our answer in shock patients. And so here's kind of how we classify our shock categories using echo. And I'll end with giving you just a summary of our 5 views and our 5E's. So thanks for listening, and I'll be happy to take any questions.
Thank you so much, Dr. Liu. That was very informative and comprehensive, and clearly thought-provoking because we're getting some great questions coming through. So go ahead and pass a few of those along to you if you are ready.
Sure.
We'll start with something from the beginning that came along pretty early. With tamponade physiology, would you mind going over the importance of respiratory variations in that assessment?
Yes, so that's a little bit more advanced. And so I will frequently do respiratory variation. So if you're looking at the general point of care echo that I described, that part is kind of without respiratory variation, or though you can have the person inspire and see if you can see volume changes or other things, I feel like that might be really hard to do. So respiratory variation is essentially by Doppler in an apical 4-chamber view, we are trying to see if they have sonographic pulsus paradoxus. And by doing this, it actually can be one of our earliest signs for developing tamponade that is that happens earlier than even the findings that I described. And so that's why we're interested in doing that. But it does involve Doppler, and I'd be happy to kind of take offline questions regarding that if people want to see what that looks like.
Yeah, and related as a follow-up to that, can you use M-mode to time RV collapse with mitral valve opening?
Yes, you can. Again, something a little bit more advanced than just regular nuts and bolts stuff. But yes, you can use kind of how you would do the EPSS in M-mode for ejection fraction. You can use the same exact technique to tell you when diastole is happening.
Wonderful, thank you. You had mentioned measuring diastolic function at one point in one of the case studies. Can you describe how you perform that?
That is also rather advanced. Done in an apical 4-chamber view and requires spectral Doppler and color. So I'm putting the color box over the mitral valve as well as spectral pulse wave Doppler, the gate being right where I estimate that the mitral valve is actually going to open in that center point, and trying to, through amplitude velocity changes, determine kind of patterns and amplitudes of the blood flow rushing from the LA to the LV. And so, yes, it involves spectral Doppler.
Great, thank you. Would you mind just reviewing, you had that great, wonderful case study of the perimyocarditis. Would you mind reviewing typical echo findings of myocarditis with a follow-up question, and I'll be happy to repeat it, of what percentage of COVID patients that you're seeing are diagnosed with myocarditis and what's their demographic?
So myocarditis is probably typically the more depressed ejection fraction. Myocarditis hasn't really been thought to produce some of the pericardial effusions, but pericarditis does more of the pericardial effusion. So that case we thought was more like myopericarditis, so both at kind of the same time. It's a little questionable now though, because maybe the COVID disease is a little different and different in the way it affects the heart, but myocarditis specifically is more of like depressed ejection fraction or global cardiac dysfunction. The percentage of COVID patients, I actually don't know because I have only really been working my own shifts, and it really, that's the only patient that I've had. So I can't say the incidence, but this person was young, which was why we found it so surprising. I'm sure if we looked at, say, something like the New York data, when they have the data, we'll be able to get more incidents. But where I am, we're not seeing the volume New York is, so I can't say with any accuracy what percentage of people have myocarditis.
Thank you. A question related to fluid status. What are your thoughts on assessing fluid status with the VEXUS scoring system? And this individual mentions that it requires a few different Dopplers, but do you think an abbreviated one using IVC and or portal vein would be helpful?
I think it has promise. Part of my problem with scoring systems right now is that a lot of them are research protocol based, and it's really hard to actually translate to true clinical scoring. I'd say it probably has promise, but I will also say that in point of care echo, at least in ED, internal medicine, maybe even family practice, anything dealing with more advanced Doppler is probably not going to be considered point of care anymore. Whereas it may have more applicability in ICUs or places where there's a big transition from ED to ICU care that's done in the ED. So I do say it's got promise, but I think anything that can be abbreviated would be very nice. It's just we'd really have to do that study. I mean, anecdotally, I would think that an abbreviated version could be shown to suffice rather than trying to get all the measurements needed. So if you can prove that, that would be greatly appreciated by all of us.
That's great. You know, along those lines of more advanced measurements that may be helpful, but would love your perspective on how that fits into emergency medicine. Measurements of strain, RV free wall strain, would that be helpful for you in ruling in or out PE and some of those regional wall motion abnormalities that we talked about?
So for regional wall motion abnormalities, the area of strain is being looked at really carefully as a future research. And the reason being is that supposedly it's been shown that LV regional wall motion abnormalities are only visible, about 30% of them, to the naked eye. And so we could potentially be missing 70% of regional wall motion abnormalities if we don't use strain programming. The problem with strain programming is that right now there's no universal standard, and that it's pretty vendor specific. So then you can't necessarily translate the results between machines. And so the other the problem right now is it requires like pristine views, of which most of us in point of care will not be able to get pristine views 100% of the time. And so those are the difficulties with that research right now. RV strain, I think it would be super helpful. There are obviously advanced ways to try to determine chronic from acute RV strain. So it would be interesting to see if any of like those packages or programs or AI developments are able to help us do that. But because we do a lot of advanced echo in our ED, I obviously see the value of learning and doing those things. I have had cases where just based on the RVSP measurements, I can say, hey, this looks like it's actually acute, even though they have other things like COPD that might make you think they have pulmonary hypertension. So I really think it's useful, but again, I realize that this is not in the general scope of regular kind of Joe Schmo users who just want to be able to see something quickly.
Great, thank you. Well, we have burned through the main questions that we received. Give just a moment here to let a couple more trickle through, but I'm going to go ahead and just thank you again for being with us, for sharing this incredible talk, your years of experience and your particular experience with COVID and the cases you shared, I know are going to be extremely helpful. And I'm very grateful, and I'm sure everyone else here is grateful for you sharing that. So thank you again. A couple things I'd like to cover as additional resources as we wrap up. You'll see here on this slide, there are a few Philips resources we want to draw your attention to. The first link that you'll see on this page is actually to our main COVID-19 specific resources kind of hub. And that also includes a lot of the recorded webinars, one of which Dr. Liu gave last week to us, which was POCUS in the ED for COVID-19 patients. So that covers a lot about what we talked about today, and as well as a good bit on lung ultrasound that I think would be a great complement to what we discussed today. So make sure you check out those resources. We also do have a large library of free open access medical education, point of care ultrasound tutorials, lectures, quick guides, and case studies available that I think would potentially be very helpful for a number of the things we talked about today. Finally, I want to make sure that you're aware we have numerous virtual options for delivering training to you to ensure that even during this time where we're all facing some pretty intense travel restrictions, there are educational materials available that could meet many of your needs. So you can learn more about that by visiting our website, which is linked here, contacting your local Philips ultrasound clinical service specialist or account manager. And I've included the contact information for those resources on this slide. So last thing here, this webinar has been recorded. And if you wish to access the recording, we will be making that available in the near future. It takes a few days to process and render and get everything uploaded to the sites where we distribute that. So we appreciate your patience in the meantime, but we will get this recording available to you as quickly as we can. Please reach out to any of the folks listed here on this slide. I'm going to copy all this information into the chat box so you can easily copy and paste it as well. And again, thank you so much to Dr. Liu and to all of you for being here today. We are very grateful, and we wish you all health and safety as you are performing your work. So thank you again, Dr. Liu. Be well, be safe. We appreciate your time, and have a great day.